Okay, so today we're going to talk about the progressive gait comp. It's August 20, or August, oh my God, October 28th. It's almost Halloween, guys. Think of it that way. So we're going to talk about progressive gait. So we're going to rehash all of those gait patterns. One of the things we're going to talk about. And then we're going to talk about what happens when we're doing these type of gait patterns. And instead of having a normal functioning adult, which most of you guys are, I'm definitely not a normal functioning adult. We get somebody now that has a neuro challenge and how that affects what we're doing with training patient, right? Obviously, our comps all stay pretty much the same at the top. It's almost like Mr. McKeever redid all these comps and made everything match at the very top, right? You guys, I will say this, you guys have been fantastic at getting informed consent. I cannot stress how good you guys have been at getting informed consent. I actually want kudos to you guys. You took me beating that into you and took it to heart. You no longer get, just come up and say, it's okay if I treat you today. You're actually giving them what you're going to do with them. And that is huge. There was just an article in the American Medical Journal of Medicine. I don't know, AGM. Yeah, AGM. Talking about how only something like 20% of physicians, when they see a patient in the the outpatient clinic setting, actually get informed consent. That they just come in and go, it's okay that I work with you, right? And that's, again, not, granted, in the the medical world, at least in seeing somebody say to see them because they're sick, I don't know. I mean, I guess you really should have informed consent with that as well, but I don't think it's as big as when we do stuff. Again, the informed consent, the big thing it'll do is it'll prevent you from getting refusals. That's a major thing. If you can do informed consent right, your refusal rates will go down. All right, for gait, let's talk. What are some major contraindications for walking a patient? Because all this goes back to where you were with regular gait. Falls, recent falls, right? Fractures, good. What could they have in their leg that's going to prevent you from walking them? Specifically in their calves. DVTs, right? And then the other major one that we have to worry about as a PTA that, most people don't think about is, has the PT evaluated them for gait? Because if the PT hasn't evaluated them for gait, we can't walk them, period. Right? If we go and look at the chart and the only thing the PT's done is assess them for bed mobility and transfers, we can't walk them. We have to pay attention to that. Right? So that's something that, PT doesn't have to worry about, because the PT, if they walk them, they're going to be the one evaluating the gait. I always question with OTA, because I talked to some of the OTA people, and evidently they're allowed to walk a patient even if their OT hasn't evaluated them for walking, which I just don't think they've gotten caught doing that yet, because I would think they'd be under similar rules with us, that they're not allowed to do that unless, it's been evaluated by the OT. Ironically enough, OTAs evidently can use the PT eval for gait, but we can't use the OT eval for that. So I don't know how that happens either. I don't claim to be an OT specialist, but if they haven't been evaluated for gait, we can't walk them. What happens if you're in the room and you're co-treating? Yeah, I never knew that either, Kaylee. What happens if you're in the room co-treating with an OT? So not an OTA, but an actual OT or an OTD. I still think they should have called themselves DOT so they could be dots, but they chose OTDs. And that OT now evaluates them for gait for OT. Can you be in the room while they're doing that? So OT helps them get up and walk to the bathroom. Yeah, you could be, there's the key thing, Adrian, right? At that point, you just assume the role of a tech, right? You're not going to bill for any of that. You're going to be there as a second set of hands, but you're not going to, that means you need to let them take lead. And I've done that before where I've had an OT with me and the patient's not been evaluated for gait by PT, and they're like, well, I need to get them to the bathroom because I need to do showering with them. Like, okay, I can help you with that. I can be here as an extra set of hands, but you need to take lead on this because I haven't been cleared to see this patient yet. That means we can't do what? We can't bill for it, right? And that's going to become hinky. We're going to talk about that a little bit more next semester, but co-treatments get a little bit hairy, right? I'm talking like Sasquatch level hairy when we start co-treating, because you have to pick which treatments, you know, OT, well, the OT will be like, well, I'm going to take therapeutic activities and I'm going to take ADLs. And then we may take Therex and Gait, right? But either way, let's say that we co-treat for an hour. It doesn't matter if we've co-treated, you know, if I've done half the treatment or they've done half the treatment, or I've done a quarter of the treatment, they've done 3/4 of the treatment, doesn't matter what happens at that point. If it's an hour, we still can only bill 4 timed units. We can't both bill 4 timed units. Does that make sense? Because in an hour, there's only 4 units. So that means we have to talk with our OT partners and our, maybe even speech. Sometimes I've done that, and be like, okay, I'll give you from 10 to 10:30, and I'll take from 10:30 to 11. And so we both break up 2 units, or maybe you know that you only did 1 unit worth of time, and you take from 10:45 to 11, and they take from 10 to 10:45. You have to be specific about that. Now, you cannot cross times. Just like Ghostbusters, you can't cross the streams. You both can't bill for 10 to 10:15. Right? You can't, dozer will not be happy. You've got to make sure that one of you is billing for that time period. Now, how about this? What if the OT is doing bedside activities, maybe brushing their teeth, combing their hair, and you put 10s on their lower back? Could you theoretically both bill now at that time? Okay, Adrian says yes, and Adrian's would be correct. Why? Does anyone know the answer why you could do that? Okay, theoretically, yes, the basis. Well, and what it is 10s is an untimed unit. We're going to talk about those, see if any of you had picked up on those type of things. Remember back in math, we talked about timed and untimed units way back when? I just went over that with the other cohort the other day. So we have timed and we have untimed units, right? Timed are supposed to be our one-on-one units, right? The time that we spend one-on-one with the patient. But let's say, let's change it up. Let's say that, they have the patient lying down and they're working upper body exercises with them. So they're have them do reaches, they're having them do arm crosses out to the side, stuff like that, maybe PNF patterns. And we are stretching their calves. We both can't bill for that same period. So we both couldn't bill for 10 to 10:15, even though those are different body parts. It's still the same unit. Now, maybe we went from 10 to 10:30, and OT says, well, I'll take the first 15 minutes, you take the second 15 minutes. That's okay. But we both couldn't write a note for 10 to 10:15 and both take 1 unit. It's not valid. You can't do that. This is why when you're co-treating, it gets a little hairy, right? You may spend 4 units of time with the patient, but only be able to bill 1 unit. So you got to kind of pay attention to what you're doing when you're working in co-treat and make sure that you guys talk about it before going in. And with neuro patients, co-treatments become really, really kind of crucial. Because let's say you have a patient that's got primary progressive MS. and you're seeing them in the inpatient center, right? So you see them in an inpatient center. And when you're seeing them in an inpatient center, the patients get super fatigued, right? Well, if that's happening, then, you know, if you both have different time periods of that patient, they may be exhausted by the time they're done with OT. So it's better to co-treat and hit them all at once and get through the treatment rather than it is to give them 2 back-to-back hour treatments and completely wipe them out. Strokes are a big thing. If you're working a stroke patient, it's usually really good to work with an OT or an OTA doing strokes, because that way you have an extra set of hands, right? It can always be beneficial to have an extra set of hands. So let's think now, we're going to talk neuro patients. What are some of your thought process of concerns gait treating, so getting a patient to walk with neuro patients? What are some of the things you'd be worried about? Balance, good. Cognitive level, yeah. Right, vision problems. Right, we're all going right along that line thought process, right? What about violence? Could that be a theoretical problem? Right? What if you have somebody that's, you know, in that confused and agitated state? That could be a problem, right? Also, some of the things we don't think about is neuro patients often have a lot of lines, right? They'll usually have maybe a heart monitor. They may have an EEG running. You know, maybe it's a stroke patient and they can't swallow, so they've got a peg tube going. So there's all kinds of lines you have to worry about. You have to pay attention to all that. That can get really kind of intense when you're working with the patient. So you have to be kind of thinking about that in advance. You know, you look at a patient that is an MCA stroke and they're a day out because PT eval them on day 0 and you're on day 1 with them. Preparing for that's a lot different than preparing for somebody that's got a total knee replacement. Right? So it takes a little bit of different kind of mental gymnastics to get ready for it. But whether it is a neuro patient, an ortho patient, a pediatric patient, a geriatric patient, it doesn't matter what patient it is. The general principles of gait training don't change. Right? If you are walking with a patient, you should be giving them consistent what? While you're walking with them. Consistent verbal cueing and feedback. Yes, right? Cueing, feedback, same kind of process there. And you'll see this. How many of you guys, did any of you see this on your clinical affiliation where the PT or PTA got the patient up and walked them and never said a dang thing the whole time you're walking with them? You just kind of walk down the hallway and back? Is that skilled therapy? Really, in reality, is that skilled therapy? Okay, Emily says no, mine was good. Michelle says she saw it once at least. Yeah, I don't think that's skilled therapy. And I'd be willing to bet most insurance carriers would argue that it's not either. Because in order for it to be skilled therapy, we have to be providing them with a service. If we're just walking along, you know, oh, look, there's a Charizard. Got to catch them all. Right? Or a Bulbasaur. I don't know. What are all the cool kids looking for nowadays in Pokemon Go? I have no idea. I just like Charizard because his name, Charizard. Anyway. If we're not providing them with feedback the whole time, now, does that mean I have to constantly be like, okay, left foot, right foot, right foot? No, but I need to watch them. Oh, okay, you missed your heel strike on that one. Let's try it with the next one. I need to be paying attention. All right, stand upright, nice and tall. Use your assistive device. Normal gait, that type of thing you have to kind of go along with. If you're not paying attention, not providing them with anything, you're not providing them a service. And if you're not providing them a service, why are you there? So let's go back and we're going to review, and I want to make my screen a little bit bigger so I can see. Actually gonna move me over here. So I got my, there we go. That way I can see me and I can see my chat. All right. So let's review. I'm gonna stand up here. I'm gonna tilt the camera a little bit. Move my chair out of the way. Let's review the gait patterns again. So what were your primary gait patterns that you guys learned in rehab? 4-point, 2-point. There's one between those. 3-point, good. Now we'll talk, the mods are considered secondary patterns. So hold on to that, Erica. So the primary patterns are your 2, 3, and 4-point pattern. Does that make sense? Those are your primaries. And then your secondary patterns are your mods. 0-point floating. Whoa, the Casper pattern. I can't believe Casper, we moved to the house with Casper the Friendly Ghost, right? All right, so let's go through the patterns one by one. Let's start with 2-point. 2-point pattern has how many assistive devices? How many assistive devices for a 2-point pattern? You get 2, right? So I'm gonna have 1 in each hand. I should have went and got my crutches out of my closet. I didn't think about that. So I've got 1 in each hand, right? They could be canes, they could be forearm crutches, they could be regular axillary crutches. And remember, with a 2-point pattern, it's just like cross-country skiing. So let's just, do I have something I can tie around my leg here? Here we go. This will work. All right, so that indicates I'm just going to use this so that my left leg is my affected leg. See if it stays there or not. So my left leg is my affected leg. So when we're walking with the 2-point pattern, it's going to be the assisted device and the opposite leg, and then the assisted device and the opposite leg. Do you remember that much of it at least? So leg assisted device, leg assisted device, leg assisted device. That's probably also one of the fastest patterns. I'm just going to hang this for my belt loop. This is not working. Now I'm not going to get it off. That's probably one of the fastest assisted device patterns. Here we go. That'll work. That is a really good pattern to teach somebody to cross the street with if they have 2 assisted devices, because it's a rapid, quick pattern. So that's 2-point. We're going to skip 3-point for now and go to 4-point. 4-point is the most cognitive pattern you have, right? Because 4-point is going to involve reciprocating gait. So with 4-point, it's assisted device, opposite foot, assisted device, opposite foot, assisted device, opposite foot, assisted device, opposite foot. You remember that much? Okay, good. Close this window down so it doesn't keep popping up. Go away. Thank you, chat. All right. So 2-point, cross-country skiing. 4-point, device, foot, device, foot, device, foot, device, foot. That is also a very, very slow pattern. Now let's think about that for a second. Now you've got a stroke patient. Why might you teach them the 4-point pattern? Okay, it's safest because it's slowest, right? Good. What else does it work? Forgot how to walk? Good. So it's working the cognition. Yeah, right. That is a heavy cognitive pattern if you think about it, right? Boom, 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 boom. I'm sure some of you, when you were doing that, got tangled up quite a bit and your cognitive process is overall okay. Right? But think about that for a patient that's got some cognition issues. That can be really, really challenging. Right? So then we have the 3-point pattern. A 3-point pattern is the non-weight bearing pattern. Right? So if this is my affected leg, that means that foot's going to be up in the air. And it's assisted devices, hop to or step through, depending on what we're doing, right? So 2-point, cross country. 4-point, device, foot, device, foot, device, foot, device, foot. 3-point, non-weight bearing, devices, hop. So those are kind of the base patterns. And then we kind of have a mod for each of those, right? Or the patterns, 2-1, 3-1, 4-1, or mod. I prefer calling them mod 2, mod 3, mod 4. Makes a lot more sense. So we'll cover mod 3 to start with. So 3-point pattern is non-weight bearing. Mod 3 is partial weight bearing. So that means I can put some weight on this foot, but not all of it. So that's where I'm going to go assisted devices with the affected leg and bring my good leg up, right? Toe tap pattern. Yeah, that's a really good way of remembering it. All right, assisted devices, good leg. The objective of those 2 assisted devices is to de-weight that affected leg. So we've got mod 3 or 3-1. The next patterns we have are mod 2 and mod 4. In order to have both those patterns, what do we have to do? Do you remember that from rehab? Yes, get rid of an assisted device, right? So again, my left leg is affected. Woo, left leg. Which assisted device would I get rid of? So Adrian says the right. So I'm going to be walking like house. Yeah, you get rid of the one on the affected side. Right? Because remember, whenever you have a set of assisted devices, it should always be good, good, bad. That's the proper way to gait train. You should have two assists and 1 bad. The bad should not have a support over here. So if I have a support over here, I'm going to have some poor gait using that assisted device to take weight off that leg. Whereas if it's over here, I'm more likely to actually weight bear onto that leg because this is kind of off to the side. Now, House, if you ever saw House walked with that cane on that affected side. That was one of the things that bugged me about that show all, 9 seasons or whatever. They've never corrected that. You'd have thought he'd have run into one physical therapist in that whole hospital. They've never corrected him. That tells me they've got a differential medicine department, but no physical therapy department. Right? Like somebody didn't walk by and go, hey, you're using that cane wrong. Because I'm sure that's exactly what you guys would do if you encounter a doctor using the cane wrong, right? You just walk up to him and go, your cane's on the wrong side, by the way. Especially somebody as pleasant as him. All right, so I've now got 1 assisted device. I was looking, I don't have anything simulated here in the box. Dang it. All right, so I got 1 assisted device. So this hand is now free. I'm just going to put it on my hip. Mod 2 is the assisted device with the affected leg and the good leg. That's your typical cane pattern, right? When you look at people that are walking with a cane, that's your typical cane pattern, right? So assisted device, affected leg, good leg. Assisted device, affected leg, good leg. Assisted device, affected leg, good leg. Wait, actually, I do have something over here. Got an old armor, so it doesn't reach all the way down, right? So boom, 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 boom. That assisted device is not the right height. Now for mod 4, it's just like the 4-point pattern, but now I only have 1 assisted device. So assisted device, bad leg, good leg. Assisted device, bad leg, good leg. Assisted device, bad leg, good leg. Does that make sense? Do you remember those now? What is the only assisted device that you can technically teach normalized gait to a patient with? What's the only assisted device? What type of walker? Yeah, rolling walker, whether it's a 4-wheel or whether it's a 2-wheel, right, front wheeled. You have, in order to have a true traditional gait pattern, because even with the cane, good idea, Erica thinking of the cane, but even with the cane, you're going to have some form of a pattern. Because if they're walking normalized gait with the cane, do they need the cane? No, right? That, and you may see that. You may see somebody walking with the cane where they're just literally dragging the tip. They probably have the cane either because they want to look cool, because everyone wants to look cool with a cane, right? There's a sword hidden in it for protection, maybe. I'm just joking. I don't think old people are walking around with swords. Why does that not surprise me? For real. Or they just weren't taught how to use that cane, so they're just kind of dragging along with them. Sword canes are pretty cool. So the only way we can get a normalized pattern is if we have something to roll with them. If they don't have something rolling, it's always going to be some sort of a pick up and go, whether it's 2, 4, 3, mod 2, 3, 4, whatever it is. It's always going to be a pick up and go. So that kind of reviews the patterns. So let's kind of go through, he's attacked by a pit bull. That would make me carry a sword cane too, I think at this point. Let's kind of step down now and let's go through the progression of assistive devices here. So where is my, there it is. So our most safe assistive device is what? Parallel bars, right? Good. So that's our most safe. What's the next step down from that in safety? Standard walker, right? Good, so we have our standard walker. Now, stepping down from that, we go to typically we'll go to a front-wheeled walker. Because front-wheeled walker, we've added some instability with those wheels. We don't necessarily have to go to this front-wheeled walker, but it's possible, right? From here, we can also then divide off. And we can go forearm crutches. We can go axillary crutches, or we can go canes. It is pretty rare in the hospital you'll ever get out here in canes. Now, I mean, you may eat canes at the hospital, maybe if you went out for lunch, but you're not going to be very often working with canes in the hospital. Most of the time when I've had a cane with me in the hospital, it's been more to do exercises with than to walk a patient, because I use it as an active assist device to move patients around, right? But for the most part, I mean, when you're in the hospital, it's pretty rare, unless the patient already came in with a cane, that we're going to get out here to a cane. So, oh my God, why did that come back up? I told you to close. Out of the forearm crutches and axillary crutches, these are not approved abbreviations, so don't use these abbreviations. Out of those two, which one of those is going to be the more stable? Cane is typically for full weight bearing, or, you know, heavy weight bearing is tolerated. Yeah, that's a really good way to look at it, Renee. I mean, if you got somebody that's just on that cusp between weight bearing as tolerated and full weight bearing, you theoretically could do a cane as well. But for the most part, full weight bearing, if my patient's not FWB, then no, we're not doing cane. But between the axillary crutches and the forearm crutches, which technically provides the most stability? Okay, see forearm crutches all over the place. Does anyone challenge that? Okay, we got some axillary crutches. All right, we got a battle going on here. Axillary crutches, I choose you. Why would I say axillary are probably the more stable? And we're going to argue either way here in a second. Why would I say axillary? Not necessarily less weight bearing, because it's my initials. I like that answer, Adrian. What does that increase? It increases your lever arm. Remember that back from physics? Because forearm crutches are only going to go from here down, whereas the axillary crutches are going to come all the way up into here. So you have a longer lever arm, which gives you a greater ability to decrease weight bearing, like Renee said. What's the downside to axillary crutches? Okay, balance of both, really. But yeah, I would say balance is one of the challenges for both. People use them wrong a lot. That is 100% right. Pressure injuries. What area are they likely to compress? The armpits, right? The axillary region. And what nerve passes through the axillary region, do you think? Yeah, good question, right? The axillary nerve. And it's very common for people to have crutches and then they do what's called hanging on them, right? You've all seen, or you guys may have done it when you've had crutches, where you kind of just like rest your weight down on those pads. When you're resting the weight down on those pads, you're literally compressing that axillary nerve. And you can end up with a palsy from it, where your arm gets, loses sensation, may lose motion. So that is one of the reasons why I may not choose an axillary crutch. Is if I've got somebody that's just not compliant, maybe then I might go forearm. Forearm crutches provide us with a little bit more mobility, right? Because they're a little bit shorter. We're able to use them in areas maybe where we can't use the axillary crutches. Forearm crutches are great for going up and down stairs. They're a little bit easier to use because nothing against, they're more like a supportive cane. Right? It takes up less space on this. And I don't know have any of you have ever tried going up and down stairs with regular crutches before, the axillary crutches? It's not much fun, is it? It's scary, right? It's not a lot of fun. But forearm crutches make it a little bit easier because they're a little bit more mobile. They're a little bit easier to kind of adjust, and you can use them kind of like a cane going up. So there are some advantages to forearm crutches. If I've got somebody that's going to be going up and down stairs regularly at home, I tend to lean more towards forearm crutches. If I've got somebody that I know needs the extra stability, I tend to lean towards axillary crutches. So there's not a hard right or wrong answer here. Sometimes the answer is, which one do you have in stock? Because I've wanted to do axillary crutches before and then gone down into the storage room to get a set of axillary crutches. And the only thing I have are forearm crutches. Well, at that point, my only option is forearm crutches. I've got to teach them how to use them. So you kind of have to pay attention to see, what you have in stock and what's valid that you could use, whether it's in the clinic, whether it's, at the hospital, whatever it is. That actually brings up a really good point that I just kind of went a squirrel around here. Now you're going in to see your patient. The PT is assessed. They're supposed to use a front-wheeled walker with them. Where do you get the front-wheeled walker from? Well, you're usually going to work with them with a front-wheeled walker from therapy, right? You're going to take one that you guys have, which is kind of like I don't know if you've ever seen some of those front-wheeled walkers that are from therapy departments, but they're kind of scary. They've been, rode hard and put away wet. They've been beat up pretty hard, right? But we don't want to send them home with a walker like that, right? So we're going to have to order from medical supplies. Who can order that walker? Does it have to be a PT? Yeah, anyone can order the walker. As long as it's documented in the chart, case management usually is the one who will take care of ordering it, right? So, but I'm saying we can go down to case management and say, hey, I need a walker for 301. We theoretically could send a tech down and say, hey, can you run down to Susie in case management and let them know that I need a walker in 301 before I can send this patient home? They can order it. It's fine. You're not, at that point, it's in the chart. That's validated why the patient needs it. Let's say the PT has eval'd the patient and it doesn't state they need an assisted device. Can we send them home with one? No. So we need to make sure that in that eval, it indicates they need an assisted device. Do you guys remember what the typical abbreviation a PT is going to put on your chart to let you know which assisted device to use? You're typically going to see this abbreviation, LRAD. We already know that A stands for assisted device. What's this stand for? You remember? Least restrictive, right? So least restrictive assisted device. If you see this, that means all of these assisted devices are in play. You can order any of them. You can't order parallel bars, obviously, right? Parallel bars are no, because they can't exactly take parallel bars. That'd be funny. Like, can you imagine if we can develop parallel bars that move along with the patient? That'd actually be pretty cool. Now that I think about it, it's actually a pretty cool idea. Like a parallel bars that move down the hallway with the patient. Come on, think about that for a second, though. Wouldn't it be a cool, that'd be like a really useful assistive device. If you had a parallel bars that you could start and it would just kind of slide down the hallway as you're walking with them. I have to develop that. Yeah, like I have the technical skill to do that. But standard walker, front wheeled walker, right? Remote control parallel bars, exactly. Kind of like my lighting in my office here. Any of those are valid assistive devices, especially if it says LRAD. You're never going to see MRAD. That doesn't exist. Most restrictive assistive device doesn't exist. LRAD does. And so that gives us freedom. Now, if the PT says we've got to use front-wheeled walker, guess what? We use front-wheeled walker. A walker with long arms. Exactly, Renee. But if they say LRAD, we're pretty open, right? I always, and I'm going to be honest with you with this, I always start with a form of a walker with a patient. It's always better to err on the side of caution than it is to toss the axillary crutches at them and then have them fall. Even a 22-year-old with an ankle fracture, you never know what's going to happen with that patient. It's better to get them up with a walker than it is initially to give them something they're going to fall down with. Plus, there's a psychological effect with that. So, you know, Renee's my patient. She broke her ankle. I go in to see her, and she's so frustrated. She doesn't want to use a walker because walkers are for old people. But I say, look, we got to use this to start with. And she gets up and uses that walker, gets out of the chair. We get back up with the walker. I see she's safe with it, and I give her some forearm crutches now to walk with. That makes her feel like she's gotten a little bit better. Even though it's something so silly and minute as that, it can be a psychological win for the patient. And we are all about those little psychological wins, right? Not like the hotel wins, but wins like WINS, right? So anything we can do to show the patient's progressing, it's huge for that patient. It's not only good for our notes, which it is, it's also good for the patient because the patient then feels like you're doing something with them. So don't always go in, you know. Now, if you see that the patient was a standby assist with a cane, you may not need to go in with a walker. I may take one with me just to be safe because I've had patients be standby assist with a cane one day and be full max assist transfer the next, right? But you kind of want to think through that type of stuff. And again, before you ever walk that patient, what should be the first thing you should put on them? Gait belt. All right, so now let's add a little bit of a kink to that gait belt idea. Clear all drawings here. I am a patient. I've got a Jewett brace on, which is one of the clamshell braces for my back because I had a spinal cord injury. Now I have a root escape injury, so I don't have a true, paralyzing spinal cord injury. I have some loss of sensation like I have my arm. But the doc's got me in a Jewett brace. Do you want to put the gait belt around the brace? So a Jewett brace is one of those hard plastic shell braces, the TLSOs. Absolutely, you can. Yeah. If it's a hard shell brace, you can. When you get down into those soft shell braces, and you get more like the abdominal binders, and we're going to talk about those next semester. When you get down to those soft shell braces, then you just have to kind of figure out, if I put a gait belt here, is it going to directly affect my patient's ability to move? You may have to move them up. You may have to move it up around the chest. You may have to kind of sling it down and across the hips. When would be the only time you would really be concerned about where to put the gait belt? If the patient has an incision. So if I got an incision on my abdomen, I've got to avoid that area with the gait belt. If I've got an incision on my back, I've got to be careful of putting my gait belt there. Now, if I've got a brace over that incision, I've got one of those Jewett braces, or I've got a Aspen TLSO or something to that effect that's protecting and covering that wound, I'm actually okay to put a belt over it, as long as that belt is not rubbing up and down on the actual incision. If I've got an open abdomen because they went in and they removed a bowel obstruction, and now I don't have a brace on, I don't want to put that belt over that incision if I'm rubbing it, because every time I'm holding on to that, that belt's going to slide up and down that incision, and it theoretically could pull out the staples or the stitches that are there. So that's the only time you really have to worry about where you're going to put the gait belt. And of course, if you got a pregnant patient, right? If you got a pregnant patient, not good to put the gait belt around baby. Right? And you can potentially cause contractions if you do that. So if you squeeze down on that gait belt, you can cause contractions. So don't do that. So we kind of went over the basics of gait here. Let's now think some neuro patients. Spinal cord injuries. So now I've got a spinal cord injury, and I've got a true spinal cord injury, whether it's a complete or whether it's an incomplete spinal cord injury. Whereabouts on the back would you need to be functional in order to actually have some form of gait? Meaning, what level of spinal cord would need to be the fully neurological level in order to be able to walk? Where do you think? How about T4? Could I walk with a T4 spinal cord injury? No, I've got no legs. So that means we need to be down at least into the lumbar levels, right? Into the lumbar levels, right? Good. So in order to have gait, we need at least which muscles? At least. The quads and the quads, hammies, glutes, and hip flexors type idea. So that means we need to go down to about what level? Think back to your myotomes. Yeah, so L2 to L5 is a really good kind of goal, right? If we have L5, we have a good chance of doing normalized gait with that patient. But we also know, are we likely to have a spinal cord injury at L5? No, because down that low, the vertebrae are so thick, it's really difficult to get a spinal cord injury, right? If we have somebody that's up in the T's, maybe T10, T12, does that mean we can't walk them? No, we can walk them, but it's going to be more of a reciprocating gait orthosis or one of those exosuits. right? It's not going to be normalized gait. There's no way I can walk somebody if they don't have any leg muscles whatsoever. They need leg muscles in order to be standing. If they can't have those leg muscles, not much they can do. Dr. O'Neill says hi. So let's say that I'm a T-level spinal cord injury. So we'll go T2. I'm a T2. Now you cannot get me up and walking, but how could you get me up and standing to get some weight bearing? What kind of a device could you put me into? Could maybe do a standard walker if you block a lot of stuff, right? There's a specific device called a stander. And the stander is nothing more than this giant thing that you strap them into, and you can actually almost use, like, they have pneumatic ones and they also have electronic ones that kind of lock around the knee, the ankles, and the hips, and will literally take them from here up to here and standing, and they're not actually standing fully on their legs. Most of it's going down through that stander, and that's what's providing the support. Could also do theoretically a tilt table. Even though they're not going to get a lot of weight bearing on a tilt table, at least it's getting them vertical. And again, we know that orienting the patient to the vertical is a big, big, big factor in getting them back to going home. So that's kind of working with that. Parkinson's patient. We're going to go another neurological patient. So now we've got a Parkinson's patient. We got a fairly advanced Parkinson's patient. So let's say we've got somebody that's 68 years old and has fairly advanced Parkinson's. Now their Parkinson's is controlled by medication. So for the most part, their tremor is controlled, but they still have festination of gait and they have freezing. That's fine, Justin. Yeah, I know Cox is having issues. Thank you. You're good. So let's say that you have a Parkinson's patient. Now, what kind of device are you thinking to work with that Parkinson's patient? So you see they've got festination of gait, so they get that little shuffle step going on. And you know they've got some freezing over thresholds. Are you going to want to go canes with this patient? Probably front-wheeled walker. Good choice, Renee. Right? 2 reasons to go with the front-wheeled walker. What does the posture of a Parkinson's patient look like? Do you remember? I talked about this. Yeah, they've got that really kyphotic posture. I'm kind of down like this, right? Now, I could correct that a little bit with canes or with assistive devices, but if I've got a walker, I can orient them to the vertical because of that walker. Right? I can force them. I can raise that walker up a little bit more than normal, and that's going to kind of force them to stand up straight. So now I'm a Parkinson's patient, right? So Parkinson's patient, if you haven't ever seen a Parkinson's patient walk, this is the way they walk. Uh-oh, I've got a spot on my floor. Right? Those constant little steps are exhausting. Just doing that, I can feel my quads kind of killing me because I did leg day yesterday. Right? So I did that. I'm shuffling. I'm taking really tiny, tiny steps. So I'm taking these little itsy bitsy steps. I'm not going anywhere. You just see my feet. My feet are going a million miles a minute. I'm not going anywhere. How can you improve my step length as a clinician? What could you do to help me? Put markers on the floor. Good. Give them a goal. Excellent. Right? So now I can go take out some markers. Something as simple as that. I know you can't see the markers over there. Let me see if I can tilt my camera anymore. So I've got markers down the floor. So I can say, okay, start here All right, your first step should reach that marker out there. Okay, good. Now bring the other leg forward. Take the other step forward. That gives me a goal of where to step, right? You can put little pieces of tape down, right? When I've seen patients in the home health setting, I've actually gotten tape out and put little marks of tape all over their floors. That gave them like pathways to the bathroom and pathways to the, living room, whatever it may be, wherever they need to go. What else can get them unfrozen? Do you remember what else can get them unfrozen? Music, right? So find out what their favorite music is. So maybe you're gonna play a little Slipknot with me. And I'm gonna walk as I'm going, right? I don't know if the other patients would appreciate that very much. Or I put my foot onto the floor. I push my fingers onto the floor. Feet onto the floor, there we go. Anything will kind of help me kind of get moving as I'm going. Music works well. What if you don't have music? What could you do? You could sing. Yeah. I'm not singing because, good Lord, I can't sing. But you can clap, right? You can break out your good old iPhone. And you get a metronome going. Right? That gives them an idea. Step, step, step. Turn into Elsa. Let it go. Let the Parkinson's go. Let it go. No, just kidding. That's the extent of my singing. Any of that is a valid technique. You can have them step for your foot, right? So put my foot here and go, okay, I need you to step to my foot. Okay, good. All right, move my foot out, step to my foot. What about my posture? What kind of cues are you going to give me about my posture? So I'm taking bigger steps because you're telling me to take bigger steps. Head up, good, right? Where the head is pointed, the body points, right? So if I pick my head up, my back almost goes back automatically. Where could you put your hand in order to give me cueing to stand up tall? Right between the shoulder blades, right? Right between the shoulder blades. You put your hand there. All right, stand up and push into my hand. Good. Now you're up nice and tall, right? I always joke with my patients that there's no money on the floor anyway. I already picked it up. There's no sense in looking. And it's not necessarily that they are consciously trying to look down at the floor. It's just that's the way their body is kind of hunching over, right? You guys all saw Ruth Bader Ginsburg, right? Did you see how hunched over she was? Like her head was way out here. Right? It's just kind of a natural effect as our body kind of declines. Yeah, exactly. How tall are you? Show me how tall you are. You're not 5 foot tall. Come on, stand up. That's a great way of saying it, Kaylee. So anything to kind of cue them to being upright. Have one of their family members, yeah, men are real quick to do it, exactly. Have one of their family members stand down at the end of the hallway and have them have to look up to see the family member, right? Or if you're working with somebody that's a dancer, tell them, okay, come on, upright posture, right? Like we're dancing, because you don't really dance like this. At least no dances that I've seen, unless it's like the troll dance, right? Upright posture is huge. The more upright they are, there's funny is if you get them upright, they're more likely to take longer steps, which is more likely to overcome fascination, which is more likely to avoid freezing with a Parkinson's patient. Do we need a break? How are we feeling? Break? Okay, let me pause sharing here. Stop share. All right, so we're back from break now. So I keep getting text messages and everything else. So that's kind of talking through a spinal cord and talking through a Parkinson's patient. Doesn't matter what you're working with again, whether it's spinal cord or Parkinson's, a couple of things you've got to remember: gait belt again and appropriate footwear. Don't get either of those patients up without either of those. Now let's think a stroke patient. So now if I'm a stroke patient, what am I likely to have on one side? One of my sides is likely to be very, very contracted, right? Or weak, right? Depending upon what I'm doing. It could be flaccid, it can be spastic. So again, we're going to pretend that I'm a right-sided stroke. So that means my left side is my affected side. Now walking me gets to be a challenge. Right? Because now when you're walking me, I may be able to get up and walk, but what am I going to do with that left leg? If I can move it at all. Drag it. Yeah, it's going to be one of these. Right? So I'm going to, you may get me up and walking, right? My foot's probably going to be externally rotated like my leg normally is. So I'm going to take a step. Right? I'm going to be basically like the Walking Dead. Right? I'm just dragging that foot kind of behind me that's dead. So that means you're going to need to give me consistent cueing for moving that leg. It's also possible that I can take a step with this leg, but I can't move this one at all. So how are you going to get this leg come up to meet up with this leg? How could you help the patient? So they can't, that left leg just doesn't move at all. Yep. You can kind of give it, I wouldn't say kick it, but yeah, definitely give it a little bit of boost to kind of slide it along, right? One of the tricks I really like to do with patients with strokes is what I call the figure 8 method. So I'll get an extra gait belt, I'll make a figure 8 out of it. I'll put the one side of the figure 8 around their leg, and I put the other end of the figure 8 around my leg. So kind of like this if this was the patient. And then what I can do is, as I move my leg, it pulls the other leg with it. It helps them kind of slide that leg. It gives them a little bit of extra active assist motion. Now, don't put it around both their legs like I just had there. That'd be a nightmare and a fall. But you're going to put one end around your foot, one end around their foot, and have it help. If you have somebody assisting you, should they help the foot move forward, or should they be guarding the patient? If it's your patient. So let's say you've got somebody that can help you kind of move that foot forward. Should they be up guarding the patient and you're moving the foot? Or should you be guarding the patient? They're helping the foot move. Right? So give them okay, so what I need you to do is when I get their right foot out, I want you to kind of help them slide that left foot forward. And again, if you remember most of the training methods we talked about, whether it's Brunstrom, or any of the other methods, we start with just working with what we've got. So if they've only got a slide, we start there. At least get some motion going. Then we can start working on, okay, pick that foot up. Okay, good, good, good. All right, now we got the foot coming forward with a pickup. Now pick that foot up and heel strike. Okay, good. Now pick that foot up and heel strike and roll through. So we start with what we've got and we work forward. With a patient that has a stroke, it's a good likelihood that their upper extremity is probably either flaccid or weak as well. Is that going to work well with the standard or a rolling walker if this arm is kind of up like this and weak? Are we going to be able to put that on a walker and actually get function out of it? No. So what might we need? instead of a standard walker. Do you remember what the stroke walker is called? Could get an armrest. Good. We could put one of those platform attachments on, or a Hemi. Good. Hemi walker is a half walker that they use only on one side. It's basically like a 4-point cane, really, right? But I prefer, honestly, if I've got one, like Sakina said, is I prefer putting one of those platforms on for the patient. Because again, remember, even with the stroke, most of the time, it's more affected distally than proximally. So they may have some weight-bearing ability through that shoulder, but when they get out here towards that wrist and everything, it's all flaccid. So if I can put them into a platform, they can still control the walker with their shoulder a little bit. And that makes them more functional than having that walker where they pick up, step, step, pick up, step, step, pick up, step, step. So I like platforms with patients that have strokes. I like parallel bars with patients with strokes, because that way I can have them kind of in a really safe environment rather than walking out in the open. If I have a light gait system where we have that harness weight suspended option where we can put them in a harness and it takes some weight off of them, that is probably the best option you have to get back to normalized gait. Because if you can take weight off them and allow them to get normal kind of sequencing, even without a full weight bearing, they can develop better habits, and then we can progress to more and more weight bearing as we go along. What are some warning signs? Let's say you're walking a stroke patient. What are some warning signs? What's the big warning sign that's going to tell you to stop? Dizziness and a sudden what? Sudden syncope or headache, right? Any of those are signs the patient may be restroking. Now, you're walking along like, oh, I feel a little dizzy. That doesn't necessarily mean they're restroking. Don't totally freak out. You may not need to stop right off the bat. If they're going all of a sudden, they're like, oh my God, the world's going black. That's a warning sign. Right? Get them seated, check them out, right? Make sure that they're not stroking on you. Because the last thing you need is to be walking a patient and them to stroke out on you. It's a lot easier to get a patient to an area that they can get medical care if they're in a chair than it is if they're on the floor. So don't let your patients, plus you also have to fill out the JACO report then, or the Sentinel report if they fall on the floor. What about vision for a stroke patient? Are they likely to have some vision issues? It's in the occipital lobe for sure, right? They may even have some in other areas too, especially if it's like posterior parietal or something like that. They may have a little bit in that as well, but it's possible. So that means that you need to be aware of that as well, because they may be trying to, you may tell them to walk down the hallway and they're going to the right. And you're trying to figure out, why are they going to the right? Well, maybe the problem is their left eye is not seeing as well. So you have to be cognizant of that. Whether it's a stroke patient, or whether it's a spinal cord injury patient, or whether it's a Parkinson's patient, what could you put in front of them that would help them see their own body posture while they're walking? A mirror. Mirrors are absolutely invaluable. It really, because you can tell a patient all you want, hey, you're leaning to the left. Come on, stand up good. Okay, Mr. Johnson, you got the really hunched position again. Stand up good and tall, right? Show me how tall you are, and you can say that to your blue in the face. If they can look in a mirror and see, oh my God, I am hunched over way far. As long as they don't have some sort of body dysmorphia where they don't realize that, right? Or have body agnosia. Well, then they can look in that mirror and go, oh yeah, look at me. I'm way over like this. Now, oh God, look, I look so much better when I'm standing up tall. So mirrors can be huge. The other thing you guys can do is if the patient gives you permission, set your phone down the hallway and record a short video of them walking. And then show them that video so they can see. right? Now, don't save their video, right? Some neurological places will actually have those recordings saved for their patients' charts as well, but you don't necessarily have to do that. But I've done that a lot where I'll put a chair down the ways and I'll set my little phone up and I'll have it record for, 50 or 60 feet. And I'll get them seated in a wheelchair, get them safe in the wheelchair, go get my phone, and then we'll review it. I'm not going to go specifically over. I'm not going to be like, okay, do you see how there you're doing this? What I'm going to first do is let them watch it. Well, I mean, if they ask, that's where you kind of have to figure out how you can do that. Anthony, it's a great question. I've sent them through my work email before, where I'll put them on my work computer and send it through my work email because I don't care if they get my work email, if that makes sense. I don't want them having my personal email, right? The other thing you can do is if you have like an iPhone like I have, you can AirDrop it. Good. That's what I was going to say. Exactly. If you have an iPhone like I have, you can do AirDrop. But even that, sometimes that gives them your Apple ID, or they can iMessage you, which can be a little bit of a pain in the butt, right? But even for you guys, like you guys can iMessage me by just sending a message to my email address. So you can set up your work email address as an iMessage. There are a couple ways you can get around that, or you can just say, okay, you know what, I'll put it on a thumb drive and I'll bring it back to you or something like that. Right? I've done it before. I've given it to them. Very rarely do they care to, honestly, but it's a really good question. If you have somebody that maybe you have an athlete or something like that that's had a stroke, yeah, they're probably going to ask you for that, Anthony. I really didn't think too hard into that, but you're right. You may have somebody that asks for it. If you do, as long as it's their recording of them, that's fine, right? I give you guys recordings of me. I could see how maybe a patient that wants to get better wants to watch it and learn from it, right? I want to watch it later on tonight when I'm sitting in my bed so I can see how I can improve. Could use their phone. Yeah, absolutely, Emily. I didn't think about that, right? I'm sure the patient has a phone. Sure, use their phone. Have a family member record it, right? Have, give it to little Bobby and have Bobby go down at the end of the hallway because Bobby wants to use the phone anyway, probably to catch Pokemon. Actually, I don't know if that's what kids do anymore or not, but probably Snapchat and Instagram. Or no, what's the other one? TikTok. Bobby wants to create a TikTok of grandma walking down the hallway. Right? That brings up a good point, though, now that I think about that. Make sure that if they do record it or you do give them a copy of it, you let them know if you want it posted or not. My personal self, I don't want any videos of myself posted on social media. I had a patient once in the outpatient clinic that did live streams of all of her visits. She came in, she was a low back patient. And all of her visits, she would sit there and she'd be like, hi, my followers. So I'm here to get my therapy today. And I'm here to see my therapist. Oh, there's Keith over there. Keith, come say hi to all my followers. No. I'm not a social butterfly. I don't want to say hi to all your followers. All, probably 3 of them. Right? But be aware of that because, nowadays I've seen it is obnoxious. Like she would literally be sitting there on traction. She'd be like, so like I'm on traction now. So they're pulling me apart. And if you look here, you can see the belts on my belly and all the way down. And they're pulling me apart like, oh my God. Why'd I put her on blast like that? Actually, this lady had something like 10,000 followers, and it was really kind of obnoxious. I'm going to be 100% honest. Like every time she'd come in, she'd have like 5,000 or 6,000 people watching her get therapy. It was really annoying. They weren't watching her get therapy, but we won't even go into that. But yeah, so she'd constantly, I'd have to tell her, I don't want to be in the video, right? Now, I don't know, maybe you don't care about it. One thing I do want to note, because I had an issue with one of our students that graduated before. If you record patients' videos of them, even if you get permission, can you post them to your social media? No. Do not do that. That directly violates HIPAA. even if the patient has given you permission. You can say, well, I talked to Janie and Janie said it was okay. What don't you have in order to post that? You don't have what? Written consent. Remember, because to think about it, to change anything about HIPAA, you have to have a written consent letter. Like if you want to make it so that your husband, I can't say husband, your boyfriend has access to your medical records in case you get sick or something like that. There has to be a written consent decree on file that he can access you, right? Even at the hospital, they're technically like, if you go in the hospital and you have a boyfriend and your boyfriend-girlfriend situation, technically, if they go to the front desk and ask if you're in the hospital, what does the hospital technically have to say? So they go to the front desk and they're like, hi, I'm Michelle's boyfriend and I'm trying to see if she's here in this hospital, right? They can't say anything because that violates HIPAA, right? Which is why if you go into the hospital, you go into the ER, you may want to make sure that you indicate that you're identifiable at the hospital, right? A lot of hospitals will have you sign off on that when you fill out the paperwork. Do you want to be identifiable in the hospital? And that's just basically saying if somebody comes to the front desk, can they tell them where you are? That happened to me when I broke my neck. I had a friend that was looking all over the place for me, couldn't find me anywhere. And the only reason they found me is because one of the docs I worked with called them and told them where I was, because they called all the hospitals. The hospital's like, I can't reveal it to you, right? But don't post patient videos on your social media. If Mr. McKeever sees it, what do you think you're going to get from Mr. McKeever? You're going to get a little nasty message from me, right? Because I do, some people do friend me. I don't know why you'd want to friend me after you guys graduate. That's kind of terrifying. Why would you want to see me anymore after you guys graduate? I'm just saying. But some people do try to friend request me or whatever after. Just don't embarrass me by posting videos of your patients. This particular one was posting videos of his patients in sniffs as he was working with them to show what a great therapist he was. And didn't realize that by doing that, you're really restricting yourself from getting a job at other places because they see you're violating HIPAA. So don't do that. I don't care if you do have 10,000 Instagram followers. Don't do that. Right? Here's an interesting one. What if, because I haven't encountered this yet, but it's an interesting thought. What if the patient wants to broadcast their treatment on Twitch or, well, Mixer's not around anymore, or YouTube or Facebook Live? Can they choose to broadcast on their own? What do you think? This is an interesting thought. I just happened to think about this. If the patient wants to do it. Yeah, so Jairo, you're my patient, and you're like, I really want to send this out to everyone so they can see me going through this. And I want to broadcast it to my Twitch followers. There's going to be some restrictions on that. Right? If they're in their own room, right. If they're in their own room and you're treating them in their room and you're okay with it, there's not a problem with it. But what if you're out in the hallways walking the patient? Why would you not be able to do it out in the hallways? Right, might catch faces of the other patients or even names sometimes, right? You go by the nursing chart, sometimes they have the names of the patients up in the nursing charts, right? On the wall. So that can be a serious HIPAA violation. And I haven't really thought about that too much, but in today's day and age, that's actually becoming more and more common. Like I thought the lady that was annoying on Instagram, but now that I think about it, that's going to become more and more common as we move more towards you guys' generation. It's a little bit more digital than us old timers. And I say this having a Twitch channel, YouTube channel, and everything else, multiple YouTube channels. But it's something to think about. So I just happened to think about it while I was going with it. It can be really beneficial though, right? Maybe if they want to do it so they can keep the videos and watch their, I don't know. I guess there's benefit to it and there's not benefit to it. All I'm going to say is if you guys broadcast me, there's going to be problems. Because I'm not exactly the most pleasant person when I'm a therapist. All right, so stroke we kind of went through. Your progressive MS, your relapsing remitting MS, your myasthenia gravis, all of that. walking a patient that has those diseases is all going to vary upon their symptoms. If they have weak legs, that's what you're going to work on with walking them. If they have a problem with reciprocal arm swing, that's what you're going to work on. Remember, with myasthenia gravis, one of the problems that you have with them is them having that chorea or choreathetosis or hemiballismus movements, meaning that when they're doing stuff, they're making these wild flailing motions. That can be really difficult if they have assisted devices. Think about it. If I've got an assisted device and I'm flailing the tips all over the place, I might take somebody out. So you may want to keep them on something like a walker where they're not flailing it around. TBIs. The major thing with TBIs and walking TBIs is understanding where they are on that TBI scale, right? Understanding where they fall. What's that scale that we're going to use to measure them by? Done by Ranchos Los Amigos, the RLA. Level of cognitive functioning scale, LCFS, right? So remember, the lower on that chart they are, the worse off they are. So let's say that you've got a patient that is confused and agitated. Are you going to want to give them crutches? Nope. It's a very good chance you might get a crutch enema if you give them crutches. So you have to be careful on what assisted devices you give patients, right? You have to be conscious about it. If they have agitation, confusion, give them a simpler device. Now, let's say I'm confused, agitated. Do you want to give me a standard walker or a rolling walker? Which is going to be easier for me to use and require less cognition? The rolling walker. Good. May not be as safe, right? Because it is definitely not as stable as a standard walker, but it requires less cognition to use because they don't have to pick it up and move it, right? They can just kind of roll with it. They literally can, Autobots roll out with it. So you have to think about that. Now, let's say I'm getting to the part where my cognition is improving. Why might I move to more separate assisted devices? What am I trying to work? So maybe instead of going from a rolling walker, now I'm going to go to forearm crutches because I want to challenge their cognition. I want to challenge their coordination, right? That brings me up a good point. So if I'm working coordination of the hands, what is that called again? Coordination of the hands is called hand-eye coordination. Good. It's also working my, starts with a D. Dexterity. Good, right? Versus coordination of the feet. What's coordination of the feet again? Starts with an A. Agility, right? So just don't ever make that mistake that you're saying that you're working agility of the hands, right? If I'm throwing this ball back and forth, I'm not doing agility drills, right? I'm doing dexterity drills. And as I change the technique that I'm doing it, it works my dexterity a little differently, right? It works my hand-eye coordination a little differently, depending upon what I'm doing. Now I put this ball on the floor and start kicking it around. Now I'm starting to do some agility drills, right? Maybe dribbling, stopping and starting the ball, stuff like that. So just be aware of that. When especially when you're dealing with athletes, dexterity is up here, agility is down there. If you're ever one that plays any role-playing games, a lot of times that'll be beaten into you anyway, because dexterity is the ability to do stuff with your hands and agility is the ability to run. in role-playing games. Dex builds for Dark Souls. I'm much more of an agility build, but okay, not for Dark Souls though, but for role-playing games. All right, so now I've got a TBI, and I am in the comatose level, so I'm down at level 1 or level 2. Am I going to walk that patient? No. Okay, good. At least I realize that. I know it seems funny, but that means you cannot bill me for gait. Because I've seen it happen where somebody will get the patient sitting up the edge of the bed and then maybe manually lift them up into standing. And they'll call that gait training. That is not gait training. That is functional activities. That's not gait. I'm going to challenge you guys here for a thought process. If I'm a max assist, can you gait train me? Think logically about this. I got the hiccups now. Yeah, I don't think so either. I don't believe if you are a max assist patient, you can effectively gait train that patient. If they're doing 10% of the work, is that really training them? Right? I don't, and again, this isn't a hard rule, but really, I won't bill gait training for patients that are max assist. I've seen it before. Where a patient, I love it. I've seen, my favorite one I saw the one time was a patient was total knee replacement. And it said, today performed gait training with rolling walker, 60 foot times 1, max assist of 3. Michelle's like, what? Yeah, think about that for a second. 60 foot times 1, max assist of 3. What did they do? Probably. They carried the person 60 feet. You literally picked them up and maybe their toes were touching the ground, right? Now let's change that up. Let's say I am max assist, but now I've got an in-ceiling harness system. And I can reduce their weight down to where I take 85% of their weight off, but now they are actively picking up their feet and walking. Could you build gait then? Yeah. Do you see the difference there, though? The difference is in their functional activity, what they're doing, right? If you're just literally dragging them down the hallway, that's not gait, right? Or maybe you put them in the pool. They're max assist on land, but in the pool, they can actually do some walking. Then, yeah, Bill Gait then. Not Bill Gates, but Bill Gait, right? It's all about understanding what you're, because here's the deal. If you've got a max assist times 3 and Medicare comes in and looks at that, that looks hinky, right? And the last thing you want is it to look hinky, because if it looks hinky, they're going to audit you, right? Patient is a dependent transfer. Walk them 40 feet. Really? I've seen it. I know you guys are kind of, I can see some of your faces, especially like, I can see Emily's face right now. It's all kind of screwed up like, huh? I've seen it happen, right? Just don't be that clinician. Think through it. If I'm not doing something, if they are not functionally performing any gait strategy, maybe it's not gait. Could I theoretically bill maybe Therex for that? Rather than trying to build gait? Yeah, maybe, right? Maybe instead of, it's not really gait training, maybe I'm strengthening, right? So I'm really not able to get them to walk normally, but I'm getting weight bearing down through their legs. So I'm doing more of a Therex or a therapeutic activity type activity. Yeah, then you can build that kind of stuff, right? But just think logically. Don't automatically assume just because they're taking a walk, you're going to build gait, right? And again, if you're not communicating with the patient, if you're not providing them feedback, right, you are not doing gait. Let's say that we get up and I've got a patient, and I don't know, we're going to say Emily's my patient this time. And Emily's just generally deconditioned. So it's not that she's got any major issues. She's just generally deconditioned. She got really sick. Maybe she got COVID. She's just generally deconditioned. And I walked 4 laps around the hospital with Emily. So we walked 4 laps. Would that be gait or would that be more thorax? Yeah, that'd be more thorax, right? That's almost the same as throwing her on a treadmill, isn't it? It's very similar to that. So you see, there's that fine line there. Now, could I have billed her maybe 8 minutes of gait because the first 8 minutes we were walking, I was cluing her into proper gait sequencing, how to use the assisted device, making sure she gets heel strike, toe off, and rolling through. Sure, I can maybe bill 8 minutes of of gait training if I'm really focusing on getting the gait cycle down first. But at the point that I'm walking laps, I'm now doing exercise. So just don't be that person. All right, one of the things that we have to think about with neuro patients that we don't really think about we can think about with a lot of patients, but we don't think about at the outpatient level is monitoring skin integrity. Because if we're talking about a neuro patients, we're typically talking either inpatient or inpatient rehab. That means they're spending extended periods of time either sitting down, lying down, sitting in a wheelchair, something to that effect. So they're likely to get skin breakdown, right? So what areas are you going to teach a patient to check for skin integrity? So you want to teach almost every patient who's had a neuro issue to check where? Where's one? Yeah, check their feet, right? So you're going to teach them. Look, bring your feet up, look at it. Oh my God, my feet are black. I went outside with no socks on or shoes on. That explains it. But I'm looking at my foot. I'm looking for any type of breakdown, right? Because if I've got neuropathy, I'm not going to feel that breakdown. What else am I going to want to do to my feet regularly? In order to keep that skin nice and supple. Clean and lotion. Good. Right? Not a good idea to just put lotion on dirty feet, just to let you know. Right? All you're really doing at that point is smearing the dirt around. It does sound gross, right? And I've seen patients like they'll slather lotion on and they go to wipe it on their foot and it's just like these black smears all over their feet. Right? So make sure you're cleaning their feet up, right? And then lotioning up. Where do you not want to put lotion at? There's one area of the feet that you don't put lotion. In the bucket. Put more in the basket. Is that what you meant? What part of the foot do you not want to put the lotion on? That's okay. I forgive you. You don't want to put lotion between the toes. Why do you not want to put lotion between the toes? What can happen there? Yeah, right. You can get that maceration effect. Now, like my big toe, I've got a huge gap between that's not really a big deal. But your other toes where it's kind of tight, if you put a lot of lotion in there and then you put socks and you put shoes on them, that can start kind of causing some skin maceration there and can break down. Now, it doesn't mean that they've got cracked skin there, we don't want to treat it. You just have to be aware of that working with the patient. Now, what if I've got Dunlap's disease and my belly Dunlaps over my belt so much that I can't see my foot? I'm looking down, I can't see my foot. How do I look at my foot? Mirror, right? You may have to go find a mirror, right? And a lot of times the hospitals give them that little like personal mirror they can use and teach them to check all of their foot. Okay, check that lateral aspect of the foot, come up between the toes, check that medial aspect of the foot, check the heel, and check the plantar aspect. Don't neglect the top of your foot as well. A lot of people forget to check the top of the foot, but think about it. That's where your shoe is going to rest a lot of the pressure, right? When you tie the shoe, if you've got a tongue that's out of place or something like that, pressing down on that skin can cause another area of pressure. So we check the foot. Where else are we going to want to check on a patient for breakdown? As clinicians. Where else do we want to check for breakdown? What am I sitting on right now? Yeah, backs of the thighs and my ischial tuberosity specifically, right? Sacrum, good, right? Now, this, I know you guys are all gone, but I don't want to look at their butt. But if you don't look at it, see what I did there? They can end up with breakdown. And you got to think about this. Are you more embarrassed to look at their butt, or would you rather see them die from a pressure injury? Right? Especially if the patient is wearing briefs. Right? Because patients get a little lazy wearing briefs. Now, if they're in the hospital, most of the time the nurse is going to check them and change them, right? But if it's a patient managing their own briefs, it's really common for patients to not change their briefs frequently, either due to cost, right? And it gets nasty. And I had one patient that told me he didn't change his brief until he went pee 4 times in that same brief. Think about that for a second. Yeah, like Jair's going, oh, right? This is a great topic right before lunch. Now I've done that. All that liquid is now resting against my skin. I'm not drinking apple juice later, exactly. But because that liquid is resting against my skin and urine has a slightly acidic content to it, right? It's going to cause maceration and breakdown. Story I'll tell you guys about next semester with wound care. One of my first wound care patients, the reason why I started seeing him for wound care was he got a pimple on his scrotum that he couldn't feel because he was he had neuropathy. That pimple got infected, and he was wearing briefs and didn't change his briefs regularly. So he ended up getting sepsis in that pimple and all the blood vessels of the scrotum, and then had no more scrotum. Right. He was literally almost killed by a zit. Right. And he spent literally, I'm not joking, I'm not even being facetious here, I think 2 months in a medically induced coma because of how bad the infection got. All from a pimple on his scrotum. Right. And it's because he didn't check his brief. So we need to check. We need to check sacrum. Honestly, and you may have to teach guys to check the underside of their scrotum. Right? Especially if they're wearing briefs. They have to be doing this. This is something you have to tell them. You don't want to be taken down by something stupid. If I'm lying down on my back a lot, where else might I have some pressures? So I'm maybe spending a lot of time on my back. Where else am I going to have some pressure injuries or potential pressure injuries? Occiput, good. Scapulas, what part of the scapula is in particular? What part juts out the most? The inferior angle and the spine, good. And then we talk about spine, well, the spinous processes, right? Maybe even the PSIS or the PIIS, all those, we got to check all those kind of bony prominence areas, the heels, right? We already checked the feet, but in the case of they're lying down a lot, we want to check their heels. Does this take a lot of time? No, it doesn't. It takes 3 seconds, right? Most of the time when you get a patient up, they're going to be in a gown. That gown is usually open in the back, right? You're going to close the gown anyway. Take a look at their skin before you close the gown. Let them know. All right, I'm just checking to see if we have any skin breakdown back here. Don't just suddenly check them out and not tell them. Right? All right, let's take a look. Let's see your back. Okay, I don't see any new skin breakdown back here. What's a sign of skin breakdown starting to happen? Okay, pruning could be, yep. Redness that doesn't do what? Okay, redness that doesn't go away, and it's not blanchable. Remember I taught you that capillary refill test where you press down, and if you press hard enough, the area becomes white? Yeah, no capillary refill, or it just stays filled, right? Unblanchable erythema, right? Unblanchable redness is a sign of starting a stage 1 pressure injury. Right, that's why, see why we're going over this. You learned something. I occasionally teach you something. I don't just ramble for 3 hours for no reason. Could be an infection, absolutely. And in our case, does it matter if it's an infection or if it's a pressure injury? Do we care? No. We just know it's a bad problem and we may have to tell them. Yeah, so let's say, let's see if I can get my hand in a different color other than white, right? If I press out here and I press hard enough and I lift off, the area is white. And eventually, as you watch it, the color starts returning until it goes back to normal. That would be blanchable erythema because it turns white and then it goes back to red, right? You can even check this on yourself if you want after sitting in class for a while. Go get a mirror, look at your butt, push down on the spots on your butt that are red from sitting down. If it blanches, it's not a pressure injury. Hopefully you're not getting pressure injuries from my classes. Does that make sense? So we want to, this is a key thing, and I'm going to, this is a big, big thing when you're talking about neuro patients. If you're in neuro, the last thing you want is a stroke patient to die from something simple like a pressure injury. They've already got the deck stacked against them, right? If they've had a stroke, if they've had a spinal cord injury, whatever it may be, that deck is stacked against them. Don't complicate it by letting them get a pressure injury. One last thing, and we'll pretty much call it here. Lines. So whether we're talking, arterial lines, whether we're talking IVs, whether we're talking catheters, whatever we're talking. What should your goal? So you come in to treat a patient and you're going to get them up and walking. What should your goal be for all of your lines? You want to get them to the side you're getting up on. Yeah, get them out of the way, right? So when you first get them up, you want to say I've got lines all over the place because most time it happens. If I'm getting up to the left side of the bed, I want to try to get all my lines over to that left side so that I'm not pulling any of them out, right? So you want to try to move the catheter bag over to that left side. You may have to take the IV pole and get it around to that left side. A good idea is after you're done treating the patient, if you've gotten them up to that left side and that those lines can be on that left side, leave them on that side. So the next person coming in that might have to help get them up, like the CNA or the nurse, they don't have to kind of jostle everything around. Now, some nurses have preferences, and I don't know why they do it, that they move IVs to weird sides and stuff like that, whatever. That's on them, right? But you want to try to get everything to one side. Let's say they're on telemetry. So what does telemetry mean? Or they'll call it tele. Yeah, they're on an EKG or an ECG, right? So that means they've got pads all over their chest, and they're usually hooked up to the wall. What do you have to do before you can take them off telemetry? Who are you going to have to talk to? Tell the nurse or the teletech. Good, right? The last thing you want to do is go in and unplug somebody from telemetry while you work with them and don't tell anyone, right? Because if you do that and you unplug them from telemetry, guess what's going to happen? What is it going to read on the screen up at the telemetry, Erica? Yeah, it's going to read asystole, or hopefully if you have a good system, it might just say lead off, right? If you're lucky. If you're lucky. If not, it suddenly looks like the patient just flatlined. Right? So don't do that to the telemetry tech and have them have a heart attack. Right? Sometimes it just disappears, right? All of a sudden the patient's no longer on it. So go up. A lot of them will put them on portable tele. Right? And portable tele is a little battery operated box. They may even come in and put it on them for you. If you know how to do it, they may just say, here's the portable tele, they're on 4, can you hook them up? And then you just unplug from the telly on the wall, plug it into the telly, and then that goes right in their pocket. That way, even while they're walking, they have an active telemetry of that patient. And the docs may want that because they may want to see how the patient does up and moving. Right? But just don't unhook them from it. IVs, we can unhook them from IVs, right? Just go in, press the off button, disconnect the IV. No. Right? I got a little spoiled with it because I had done phlebotomy and a lot of the nurses knew that I knew how to unhook and rehook up IVs. So they were like, okay, just take them off the IV for right now, shut it down and put it on hold. I would get a little spoiled because I do that. And then I had to stop doing that because what I caught was my students doing it when I had them. And I didn't think about that. I'm said they're going to do exactly what I do. And they were mimicking me. Well, the difference was I knew how to put the IVs in and take them out. Whereas a student, if they pull out that IV for good, that nurse is going to be pretty PO'd at them, right? So if you have to have the IVs taken off, you go get the nurse. Hey, can we put this patient on hold on the IVs for 5 or 10 minutes while I walk them? Here's a thing to help with that. I want to get up and walk the patient. Can we take them off the IV for a few seconds? I want to take them to the bathroom too. The nurse is more likely to let you to come in and get you unhooked from the IV because you're helping them. Exactly. Right? So there are little tricks you can do that makes you less exasperating to nurses. Because you got to think about it, most of the time the nurses, they might have 15 patients. And you may be seeing 8 of them, and she has to come in and take all 8 of them off IV or whatever, depending upon what they're on. If the patient's getting blood, should we treat them? Probably not. Right? If they're getting blood, their H&H counts are probably low, hematocrit and hemoglobin. So we may not be wanting to treat them at that given moment. Check with the nurse. It's possible, but more than likely, if they're getting blood, we may just want to wave off and come back in a little bit after the blood's done. Because they're probably going to be lightheaded as it is. If they're low on blood, that they're getting blood, they're probably going to be lightheaded getting up. Better to wait till they have that nice blood in them and it's circulating before you get them up. Patients on an NG tube, nasogastric tube, whether it's a feeding tube or whether it's a tube that's draining acid out of their stomach or bile out of their stomach. Can we unhook that? No. So if you're noticing anything, what is it saying about all the tubes? Don't unhook them. Right? So be aware of what you're allowed to do and what you can't do, right? Patients on a vent or just a respirator, right? They've got oxygen pump going in. All of a sudden you sit them up and that vent pops off. Is your patient gonna die? Oh my God, it popped off their throat. Oh my God, they're gonna die. Not initially, right? I can't tell you how many times I've popped off the trach. It happens. Those trachs aren't held on very tight. I'm going to tell you, right? It's just kind of a slip grip over it. Pops off, call for the nurse. Check with respiratory, have them pop it back on quick. Your patient's not going to instantly die if you pop off the trach. So don't freak out is what I'm saying. If the respirator or ventilator starts going beep, 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 don't freak out. It doesn't mean the patient's dying. You suddenly see a flat line and your patient's eyes are rolled back in their head and you're not getting a pulse. That could theoretically mean your patient is dying, right? But just because something happens with the line doesn't necessarily mean your patient's going to die. You pull out an IV, it's going to happen. IVs are going to come out. Don't freak out, right? Don't totally lose your mind. Yeah, the nurse is probably going to chew you out a little bit, but it happens. It happens to the best of us. I've pulled catheters out on accident. It's not good. It's not comfortable for the patient. Yeah, right. Eric's like, eek. But sometimes just weird stuff happens. I've had patients pull their own catheter out mid-treatment. Right? Central line is the bad one. You're exactly right. So central line is going to go where? Into their neck. Yeah, so I've got especially any type of Swansgang catheter going into my neck, specifically into any of my major arteries, those are the ones you want to really be super careful of, because a lot of them are in which artery? What artery do you think they're going into? Yeah, it could be going into, I've seen it where they're going into the carotids. Right? And if that carotid gets ripped open, that's a lot of blood pressure. And you're going to be bathed in, it's going to look like a horror scene. Right? So just be aware of that. So if I'm absolutely talking about lines, the ones I am most careful of, any IV in the neck, really careful of it. Chest tubes, very careful of, right? Because they are going in through the ribs, usually into the pleural space. Don't pull those out. That's bad, right? I think those are another one that I'm pretty careful of. IVs, for the most part, I'm not totally like freaking out careful of, but I am careful of them. It's not like I'm saying, yeah, they do hurt. Chest tubes hurt like crazy. Catheter lines, like the regular kind of indwelling catheter. Be a little careful of them because it's really uncomfortable to pull on those. Fecal catheters, definitely be careful with those because they're hard to get back in and functional again. So if they've got it in and the fecal catheter is working, the nurse is going to be really upset if you screw that up. Trying to think there's anything else. NG tubes going down the nose, not really a huge, I mean, yeah, if you're not going to pull it out because it goes all the way down to their stomach, right? Any type of feeding tube in the stomach, be careful of, because that's an open area that can get infection. I had a pediatric patient once that the mom just decided one day she wasn't going to give their kid perinatal nutrition. She stopped giving him food through that tube, and she just pulled the tube out on her own at home. Is that going to be a problem? Yeah, because that tube, yeah, so like Emily's like, what? That tube goes into his stomach, into a hole in his stomach. And she just yanked the tube out. Right? The kid got a really, really bad infection from it and got really sick off of it. She didn't know any better. I mean, I hope she would have known better, but she just didn't. It wasn't, yeah, it was a stupid mistake. We'll just go there. Pulse oximeters. You pull those off, not really a big deal, right? You lose pulse ox, just get a new pulse ox. A lot of the pulse oxes you're going to see in the hospital are taped on the finger, and they have a cable that goes to the pulse ox in the wall to monitor. If that comes off, just go get a new one, put a new one on. It takes 3 seconds. Trying to think if there's any other lines that are kind of important. We talked about EKG. EEGs, the electroencephalogram, it's very rare that you're going to see a patient with that on while you're working with them. I mean, you may get called in to do some motion with a patient on an EEG, but it's pretty rare that the patient is going to be on an EEG while you're working with them, or even an EMG while you're working with them. Intrathecal lines. There's one I forgot about. Intrathecal lines. Where is that going? Intrathecal. The other term for that is epidural. Where is that going into? Those of you that have had an epidural before, yeah, into the spine. Probably not a good idea to pull those. Right? What kind of medicines will we deliver epidural? A lot of muscle relaxers, like baclofen, maybe some cyclobenzaprine, but mainly it's baclofen and a couple of the other antispastic drugs. You know, if they've got an insulin pump, again, don't pull it out. It's not going to be the end of the world. Don't pull it out. Right? It's just the idea of managing your lines, getting them all to one side and being careful of it. If they have a nasal cannula, they got rubber nose up their hose or rubber hose up their nose, and you pull it off the wall, are they going to die? No, just put it back onto the wall, right? That one's pretty simple, right? If your patient's on 2 liters of oxygen, right? Yeah, the nurse will be angry, right? Patients on 2 liters of oxygen. Really, 2 liters is nothing. Honestly, 2 liters is what they throw any patient on pretty much that comes in nowadays, because they're always worried about COVID at this point, right? And they're just thinking better to give that patient more oxygen and flood kind of their lungs with oxygen than it is to have them short on oxygen. If you get up to those 10-liter ranges, that's pretty forceful. I've seen a patient on 10 liters of oxygen. Sounds like there's a jet engine going into their nose, right? That means that patient is not processing oxygen at all. Don't pull that off the patient. They're going to go cyanotic on you. You just have to kind of be careful with their lines. And then just watch for any warning signs, sudden headaches, any signs of autonomic dysreflexia, and you should do what? So you're working with me on a spinal cord injury, I start sweating, check the catheter. What's the other part of that? Yeah, stand them up, right? Change your vertical position, check the catheter, right? I'm starting to sweat. I'm starting to become kind of delirious. I've got piloerection, any of that, that's a sign of autonomic dysreflexia. Stand me up, check the catheter. Stand me up, check the catheter. Oh, JP drains. Does anyone know what a JP drain is? This will be kind of the last topic. Yeah, it's a drain that it's a drain that drains the joint space. Right? Those little bulb things. Exactly, Kaylee. So a lot of them look like little, I don't know what happened to my little squeezy ball. It vanished on me. I threw it somewhere. Anyway, looks like a little squeezy ball. Right? And usually at first, they're all compressed. So they're kind of collapsed on each other. And then as blood flows into the area, it opens up and sucks the blood out of the area. Right? There's a little kind of funnel inside that area that kind of sucks the excess blood from the, especially, you know, patients have had total knee replacements, total hips. I had one for my neck. There's a JP drain, and that left a nasty scar on my shoulder here. But the goal was to kind of drain that excess blood out of that area so that you didn't get a nasty clot. Right? All of those go in, and there's a stitch over them. So the likelihood of you pulling those JP drains out are pretty low. But that doesn't mean you just let them dangle by the cord, right? They usually have a little bit of a safety pin on them, and you just safety pin them to their gown. Or you throw it in the pocket of the gown. If it's down on the knee or the hip or something like that, safety pin it to the gown so it doesn't drag behind them. But if you pull one of those out, is it the end of the world? No, it's just going to be a bloody mess. That one's funny. I think that's it for talking about lines and stuff that I want to kind of cover with this. Just think if there's anything else. The only other thing I'll say is just be aware if your patient wears visual devices to help with seeing. If the patient has to wear glasses to see, make sure they have their glasses before you walk, right? Because you may think that they're all over the place and their problem is their balance, when in reality is they can't see. If I take my glasses off, I can walk pretty well. I'm a functional ambulator without my glasses. I don't see well, right? But now you have me coming out of anesthesia, or you have me on pain meds, and I don't have my glasses, I might be all over the place. So make sure your patient, if they wear visual corrective devices, have them. If they wear contacts, well, let's see if they have their safety their glasses, their backup glasses for them. Most patients that wear contacts have a backup pair of glasses. Have a family member bring them in. It'll make your life a lot easier treating them. All right, any questions? That was a lot today. Anything you can think of that worries you about either gait training a neuro patient, worries you about lines and tubes, because you guys are going to get ready to go on your long clinical, so you're more likely to encounter all of these conditions and be responsible for actually treating a patient kind of full time. This is the fun stuff. It is. This is why I like kind of treating neuro patients, is because it's never the same thing every day. And it's never the same lines. Today they could have 50 lines in. Tomorrow they may just have an IV. Right? Think about, if you do have a patient with multiple lines, think about how you're going to maneuver with those lines. You need to have a plan. You can't just expect, if the patient's a max or a mod assist, for them to help carry their lines. You have to have a plan, right? And just like everything Murphy's Law says, any plan can fail, right? And if it's going to happen, it will happen. Those are the things you have to prep for. I always assume if I've got a neuro patient, they are going to fall. Even if they're a min assist, I'm going to assume they're going to fall. Because if I assume they're going to fall, I am prepared for it. I always assume the kids I work with are going to fall, because invariably they will try to. So you got to be thinking in advance of this stuff, right? Thinking in advance, what happens if, what happens if, what happens if. Let's say you're in a clinic now and the patient's got a, I don't know, let me think of kind of a weird artery in the brain. The hypothalamic artery. And they had a stroke in the hypothalamic artery. And you don't know what a patient with hypothalamic artery syndrome looks like. Look it up. Right? Look at their chart and look it up. You may look it in the book and they'll say that they did this, this is what they look like. And you go to look at the chart, it looks nothing like it. Right? So just make sure that you're doing your research. If you don't, again, if you're in a clinic or you're in the hospital and you don't know how to treat a specific thing, that means that night you should go home and look that stuff up, so the next day you're not in the same knowledge hole. Right? That is what I'm looking for as a clinician having a student. I don't expect you to know everything. I do expect you to know the basic stuff. I expect you to know what muscles make up the rotator cuff. I expect you to know how to guard a patient. I may not expect you to know how to treat somebody that's got a middle cerebral artery stroke, because you can't really simulate that very well in a school setting. But I expect you to have the basics of it. And if you don't understand it, to go home and look at it that night and come back to me and say, hey, you know, I was looking at this. Can we try this with the patient today? I was reading the research, this would work. You are more likely to get an advanced proficiency or a higher level score on me if you are one of those students that goes home and reviews every night, then you are one that just comes in and is like, derp, I don't know. What do you want me to do, Bob? Show me what you want me to do. Show me everything. I don't know how to put socks on a patient. Right? That's going to get you to fail. So you want to make sure that you guys are researching this type of stuff, going home and looking at stuff. All right. I think I'm pretty much done. Then I'm going to stop sharing here. Go over there, mouse. Stop sharing.